Hello friends, today I am going to present an interesting case of sheathless RIRS in an unstented patient with upper ureteric kink done with TFL laser. The patient is a 65-year female present with left flank pain, a PUJ stone of 11 mm and upper calyx of 5 mm stone. The patient was afebrile, RFT was normal. The patient had some urine infection but the culture was sterile. The patient was given antibiotics for 5 days and she was planned for left RIRS. The NCCT KOB shows the very hard stone of 1700 ounce unit at the PUJ and an upper calyx stone of 5 mm and hydronephrosis is appreciable. I always begin my RIRS with a semi-rigid ureteroscopy, and as expected in this case of unstented patient, the lower ureter was narrow. So the first challenge in this case was a narrow lower ureter, URS 6 French not able to pass, hence I did a balloon dilatation. I always prefer a balloon dilatation over the serial ureteric dilators. Balloon dilatation is appreciable in this picture. I do not use any contrast because after the use of contrast the balloon doesn't be fit for reuse. The balloon dilatation is done under cystoscopic and C-arm guidance. The balloon is kept inflated for around 2 to 3 minutes. After the use of balloon, I get a very good concentric dilatation of the ureter and my semi-rigid ureteroscope is able to cross up to the upper ureter. The second challenge was putting an excess sheath of 9.5 11.5 French. The ureteric excess sheath was not able to cross the lower ureter, and after much jugglery I decided to go for a sheathless flexible ureteroscopy with FlexX2S. In this case, the guide wire was obstructing the irrigation, hence I had to remove the guide wire. The flexible ureteroscope was able to cross up to the upper ureter. But another challenge appeared and the flexible ureteroscope could not negotiate the upper ureter beyond a certain level. Hence, I did an RGP and it showed me an upper ureteric kink. As we can see in the video, the upper ureteric kink is visible and I had to negotiate the upper ureteric kink with the help of a glide wire, Terumo glide wire. And mind you friends, this was the most difficult part of the surgery, negotiating the kink, and sometimes it can be really damaging to your scope, especially if it is not the disposable one. Once I was into the system, I begin to lace the hard PUJ stone with the thulium fiber laser. I always prefer dusting over the fragmentation using very high energy settings in the form of high frequency and low energy. Excellent dusting is done with the help of TFL laser. I always take care of the irrigation. I do not use any of the pressurized irrigation. I use a 100 cm extension tube, and especially in this case because I was not using a ureteric excess sheath, I take care that very slow and gradual irrigation is done so as to keep the intrapelvic pressures low. This really helps in decreasing the chances of urosepsis. After doing the PUJ stone, I went to the upper calyx and dusted the upper calyx stone, taking care that I do not perforate the system. Once I am done with the laser dusting, I always do an RGP, confirm that there is no extravasation of the contrast, and I go into each of the calyces to confirm a complete clearance. Fine golden dust is appreciable at the end of the procedure, which gives me a surety about my clearance on table. The post-operative outcome was uneventful. Complete clearance was achieved on table. The operative time was 1 hour and 15 minutes with the lacing time of around 15 minutes. The patient was able to discharge within 48 hours with an added intravenous antibiotic for next day. No urosepsis was recorded. Friends, to conclude, RIRS is difficult in unstented patients. Pre-stenting is ideal, but sheathless RIRS can be done, especially in female patients with FlexX2S. Balloon dilatation is helpful. RGP is advisable, and upper ureteric kinks can definitely be challenging. Thank you.